What the Study Says.
Welcome back to What the Study Says. I'm Dr. Kai.
And I'm Dr. May.
Have you ever maybe mapped out every single bathroom on your commute?
Oh, yeah.
Or perhaps hesitated to laugh really hard at a joke, just in case?
You've been there.
Well, today we're diving into a topic that affects millions, but often remains this silent struggle. Urinary incontinence.
Right.
It's common, it's often treatable, and despite what you might have heard, it is not a normal or inevitable part of aging.
Absolutely. We're talking about that involuntary leakage of urine, a condition far more prevalent than most people realize. And so many people suffer in silence thinking there's no solution.
But that couldn't be further from the truth.
Exactly.
Exactly. We're here to unpack the latest on why this happens, who it affects, and most importantly, what can actually be done about it. Because knowledge is power, right? And in this case, that power might just keep you drier and help you reclaim your daily life. So let's get into it.
Okay, let's start with the fundamentals. What exactly is urinary incontinence, and just how widespread is this issue?
Okay. At its core, urinary incontinence is simply involuntary loss of urine. Simple definition. But the numbers, they're truly eye-opening.
Yeah.
For women, studies show prevalence ranging really widely, from 10 up to 60%. Some even indicate as high as 62% in non-pregnant women over 20.
62%.
Yeah. And if we look at the over 50 crowd, that number can jump to 50, even 70%.
Wow.
And for men, it affects about 11% of those aged 60, 64, but that soars to 31% for men 85 and older. So, this is far from a rare occurrence.
Those are staggering figures. So if it's that common, why don't we hear more about it? Why isn't it, openly discussed?
That's a really crucial point. Embarrassment. It's a major, major barrier. Many individuals are incredibly reluctant to even bring it up with their doctor. They might fear surgery, or maybe they just don't realize that effective treatment options even exist.
Right.
And it's particularly true for men. There's often even less likely to seek care than women are.
Interesting.
So this reluctance means it's frequently underdiagnosed and consequently undertreated. There's a striking statistic. Nearly 3 out of 4 women with incontinence haven't even discussed it with their GP.
3 out of 4. Wow.
Yeah, it really remains a silent struggle for so many.
So it's a quiet battle for a lot of people, and it's not just one type of leakage, is it? Can you break down the different flavors of incontinence for us?
That's right, yeah. There are several distinct categories, and each one has its own characteristics. Knowing the type is really the first step in figuring out the right solution.
Okay.
So first we have stress urinary incontinence, or SUI.
Okay.
This is often described as the oops, I sneezed moment. It's when you lose urine during physical activities like coughing, sneezing, laughing, lifting, or exercising.
Right, the pressure thing.
Exactly. It typically happens because of weakened urethral sphincter function. Think of the sphincter as the muscle acting like a valve that holds urine in. This is commonly seen in women after childbirth or in men after prostate surgery. And importantly, you usually won't experience leakage from SUI while you're asleep.
Okay. So that's SUI. What's next?
Then there's urgency urinary incontinence, or UUI. It's also frequently called overactive bladder, or OAB.
OAB.
This is the gotta go now type. You feel this sudden, compelling urge to urinate. It's so strong that you might leak before you can even reach the bathroom.
Ah, okay.
This is usually linked to uninhibited, sort of involuntary contractions of the bladder muscle itself.
Right, the bladder's squeezing when it shouldn't.
Precisely.
Yeah.
And, as you might guess, when you experience a combination of both SUI and UUI.
Let me guess, mixed.
You got it. Mixed urinary incontinence, or MUI. It's like getting the double whammy of bladder issues.
Okay, double trouble.
Then, a less common but important type is overflow incontinence. This happens when your bladder doesn't empty completely.
Right.
So it leads to this continuous dribbling. It's almost like a perpetually overflowing bucket. This type can be more concerning because if it's left unaddressed, it might indicate underlying bladder or even kidney damage.
Okay.
So that's one to watch.
Good to know. Any others?
Yeah, for men specifically, we often see post-void dribbling, PVD.
PVD.
Yeah. It's simply the involuntary leakage of urine after you finished urinating and thought you were done. Just a little bit more escapes.
Ah, okay. The after drip.
Kinda, yeah. And finally, there's functional incontinence. Now, this isn't actually a problem with the bladder itself.
Oh.
It's more about an inability to get to the bathroom in time, maybe due to physical limitations like severe arthritis making it hard to move quickly, or maybe cognitive issues that impair judgment or mobility.
So the plumbing works, but you can't get there fast enough.
Exactly. For example, studies show that a significant percentage of older women with daily incontinence report at least one functional disability contributing to their struggles.
Okay, so we've got the different types sorted, but what actually causes these issues? What, throws a wrench in the works and leads to these different kinds of leakage?
Right. Well, it's often multifactorial. That means many things can contribute, and it's rarely just one single culprit.
Okay.
Now, while the risk does increase with age, it's really critical to understand that it's not just age itself.
Right, you said that earlier. Not inevitable.
Exactly. Often it's related to other health conditions that tend to accompany aging, not simply the passage of time.
Makes sense. What are some big ones?
Okay, obesity is a really significant risk factor, especially for women. Being obese can nearly triple your odds of experiencing incontinence.
Triple. Wow.
Yeah. But the good news here is that studies consistently show losing weight can significantly improve or even resolve symptoms, whether it's through lifestyle changes or surgical interventions like bariatric surgery.
That's encouraging.
Definitely. For women, childbirth is another well-known factor, particularly vaginal births. They can increase the risk of stress incontinence. But it's worth noting, even women who haven't given birth can experience bothersome urinary incontinence. So it's not exclusively a post-childbirth issue.
Good point. What about for men?
For men, prostate issues are common culprits. A condition called benign prostatic hyperplasia, or BPH, basically an enlarged prostate, can cause symptoms.
Right, BPH.
And prostate surgery, especially radical prostatectomy for cancer, can sometimes lead to stress incontinence. That's due to potential damage to that urethral sphincter we talked about earlier.
Okay.
And, of course, certain neurological conditions, things like stroke, Parkinson's disease, multiple sclerosis, or spinal cord injury. They can all disrupt the delicate nerve signals that control bladder function.
Now, here's where it gets truly interesting and perhaps a bit surprising for many listeners. You mentioned some daily medications could actually be contributing.
Absolutely.
Yeah.
It's a common, often overlooked factor. Many drugs that you might not even suspect can impact bladder function.
Like what?
Well, we're talking about things like older first-generation antihistamines,
Mm.
the ones in some over-the-counter allergy meds. They can relax the bladder maybe a bit too much. Decongestants can sometimes have the opposite effect, increasing urethral sphincter tone, making it harder to empty completely.
Huh.
Certain pain medications, like opioids, can decrease your sensation of needing to go, so you might not realize your bladder's full.
Right.
Even some blood pressure medications, particularly ACE inhibitors, they can sometimes cause a chronic cough.
Which would worsen stress incontinence.
Exactly. And yes, some antidepressants and antipsychotics can also have mixed effects on bladder control. It's quite a list.
It really is. And let's not forget the more obvious suspects like excessive caffeine and alcohol.
Oh, definitely. Well-known bladder irritants,
Yeah.
they can certainly worsen symptoms.
Right. Plus, you mentioned something as seemingly simple as chronic constipation.
Yes. Constipation can put direct physical pressure on the bladder and contribute to leakage. So sometimes just tackling constipation can make a surprisingly big difference.
So lots of potential contributing factors. How do you figure out what's going on when someone comes in?
Well, when you talk to your doctor about this, the diagnosis often begins with a good old-fashioned detective story, your medical history.
Okay.
Don't be shy. Describing your symptoms, even the embarrassing ones, is absolutely crucial. The initial evaluation aims to classify the type of incontinence and identify any potentially reversible causes.
So you're looking for everything from how often you go to what triggers the leakage and how it's actually impacting your daily life, right?
Exactly. We'll also do a physical exam. For men, a digital rectal exam is important to check the prostate. And a simple urinalysis is always key. We need to rule out a urinary tract infection or blood in the urine first, because those need to be addressed.
Right. Rule out the simple stuff.
Precisely.
Yeah.
And a common misconception is that you immediately need complex tests, but often the most insightful tool is simpler than you'd think, the bladder diary.
Ah, the pee diary, as some might call it. How does that actually work?
Exactly. It's kind of like a Fitbit for your
Yeah.
bladder. For a few days, you just record your fluid intake, when you urinate, how much, and when you experience any leakage.
Right.
This helps us see patterns, understand your bladder's true capacity, and identify your shortest voiding intervals. It provides invaluable insights that you just can't get from a quick office visit.
That sounds surprisingly simple, but really powerful for uncovering hidden patterns. What else might come up in a typical diagnostic process?
Well, we might also measure your post-void residual, or PVR.
BBR.
Yeah, that's how much urine is left in your bladder after you try to empty it. It helps us see if your bladder is emptying completely, which is important for ruling out overflow.
Makes sense.
For men, uroflowmetry is also common. You simply urinate into a special device that measures the speed and volume of your urine flow. It helps identify any blockages or potentially weak bladder muscles.
Okay.
And for women, a bladder stress test can be performed right in the clinic. Basically, you cough vigorously with a full bladder while the clinician observes for any leakage.
Sounds direct.
It is direct, but very effective for diagnosing stress incontinence right then and there.
I imagine many listeners think about those really complicated, maybe invasive tests when they hear about bladder issues. Is that always necessary?
That's a great point, and perhaps one of the most surprising findings for many people. Despite what you might think, complex tests like urodynamics, which involve catheters and pressure measurements, are generally not needed for the initial evaluation of most patients.
Really?
Yeah, they can be invasive, they're costly, and importantly, studies haven't consistently shown they actually improve outcomes for the majority of uncomplicated cases.
Huh.
We typically reserve those for more complex situations, like when initial treatments haven't worked, or when the primary type of mixed incontinence is really unclear, or if surgery is being actively considered.
So, simple steps first, usually. But there must be some red flags, things that would warrant a specialist referral, right, to a urologist or urogynecologist.
Absolutely, yes. If you experience recurrent UTIs, pain with urination, blood in your urine, hematuria, significant prostate issues, advanced pelvic organ prolapse if you're a woman, or any new neurological symptoms.
Okay.
It's definitely time to see a specialist. Also, if there's persistently a large amount of urine left in the bladder after voiding, or maybe a history of prior pelvic reconstructive surgery or radiation, a specialist consultation is definitely warranted.
Okay, that's clear. So this brings us to the empowering part, treatment. The most important message here seems to be that incontinence isn't a life sentence. It is highly treatable. Where do we typically begin?
Right. The first line of defense is almost always conservative, non-pharmacological approaches. We really want to empower you to take control. It's often a stepwise process focused on improving your quality of life. Full continence isn't always the end point, but significant improvement is incredibly common.
Okay, so what does that look like?
Well, it includes foundational lifestyle tweaks. We talked about obesity being a factor. So managing your weight, if you're overweight or obese, can significantly improve symptoms.
Right, the triple risk factor.
Exactly. Also, modifying your fluid intake. This doesn't necessarily mean drinking less overall, but maybe avoiding excessive amounts, or those bladder irritants like caffeine and alcohol. Timing your fluid intake, especially reducing it before bed if nighttime urination is an issue, can be very helpful.
Makes sense.
And addressing constipation, as we mentioned, can alleviate direct pressure on the bladder. Even quitting smoking can help. Smoking has been linked to an increased risk.
Okay, lifestyle adjustments. And then, of course, there are the mighty Kegels.
Indeed. Pelvic floor muscle exercises, commonly known as Kegels, are truly foundational for both men and women.
Right.
These exercises strengthen the muscles that support your bladder, and they can even help suppress those urgent bladder contractions in OAB.
How do you do them right?
Consistent, proper technique is key. The aim is generally 3 sets of 8 to 12 contractions, held for 8 to 10 seconds each, ideally 3 times a day.
That's quite a commitment.
It is, but what's compelling here is that studies show that more intense, more frequent exercises, and even using e-health apps for instruction and feedback, can significantly boost their effectiveness. We have high certainty evidence showing these exercises are more beneficial than doing nothing for all types of incontinence.
That's great evidence. What about for the urgency type?
Right, for urgency issues or OAB, we employ bladder training. I sometimes call it bladder boot camp.
Huh, I like that.
It's really about mind over bladder. You start with short timed voiding intervals based on your bladder diary, say every hour,
Okay.
and then you gradually increase those intervals over weeks. If you feel an urge before your scheduled time, you use distraction techniques like doing mental math or focusing on your breathing and quick, strong pelvic floor contractions to try and flick the urge away.
So you're retraining the bladder signals.
Exactly. It takes patience and consistency, but it really works to regain control over those urgent signals.
Now, while the goal is obviously to reduce or eliminate the leakage, what about managing symptoms with dignity in the meantime? Pads and things.
That's a crucial aspect.
Yes.
While the primary goal is treatment, pads and protective garments can be incredibly helpful for managing leakage with dignity and confidence.
Right.
But we always emphasize that they are a management tool, not a cure. They provide comfort and reduce embarrassment, which is huge, but continuous use can sometimes lead to skin irritation, so finding and treating the root cause is still paramount.
Okay. And for men, are there other options?
Yes, for men, there are also external options like condom catheters, which fit over the penis, or even penile clamps for very short-term use, maybe during a long meeting or a movie.
Clamps.
Yeah, they gently compress the urethra. But the key with these is to avoid continuous use and, as you said, focus on getting to the underlying cause, as chronic use can carry its own risks.
Okay, so if those conservative measures, lifestyle, Kegels, bladder training, aren't providing enough relief, what's the next step? Is that when we move to medications?
Precisely. If conservative measures aren't enough or aren't providing the desired improvement, we then consider pharmacotherapy, which means using medications.
Okay. What are the main options?
Well, for urgency urinary incontinence, UUI, or overactive bladder, OAB, we have two main classes of drugs. The first are the beta-3 adrenergic agonists, drugs like mirabegron or Vibegron. These work by relaxing the bladder muscle, allowing it to hold more urine.
Okay.
They are often preferred, especially for older adults, because they tend to have fewer side effects, particularly less impact on cognitive function, things like confusion or memory problems.
That's a big plus for older folks.
Definite. The other main class is antimuscarinic drugs. These work by blocking the nerve signals that cause those unwanted bladder contractions.
Right.
They are effective, but they can come with some bothersome side effects like dry mouth, constipation, blurred vision. And yes, they do carry a potential risk for cognitive impacts, especially with long-term use.
So you have to weigh those risks.
Absolutely. When an antimuscarinic is chosen, we carefully consider these factors, especially in older patients. Sometimes we might prefer specific ones like trospium or darafenacin, which are thought to have less impact on the brain.
So it's truly a careful balancing act between effectiveness and potential side effects.
Yeah.
Really finding the right fit for each individual person.
Absolutely. It's very personalized. And for men with LUTS, lower urinary tract symptoms, which often includes urgency and frequency alongside emptying problems.
Right. Often linked to the prostate.
Exactly. There are additional options. These include alpha blockers, which help relax the muscles around the prostate and bladder neck, making it easier to urinate, or 5-alpha reductase inhibitors, which actually shrink an enlarged prostate over time.
Okay.
Sometimes a combination of these drugs works best for men with both storage and emptying symptoms.
And what about for women, particularly around menopause?
Great question. For peri- and postmenopausal women who are experiencing vaginal dryness or atrophy, topical vaginal estrogen can be a real game changer.
Topical, meaning not pills.
Right? Creams, rings, or tablets inserted vaginally. It can significantly improve both urgency and stress incontinence symptoms by improving blood flow and tissue health in the urethra and vagina. We often suggest it as a first-line therapy for those women with vaginal atrophy.
That's interesting.
Yeah, but it's important to distinguish this from systemic, like oral, estrogen therapy. Evidence suggests that systemic HRT might actually worsen urinary incontinence. So topical is key here.
Good distinction. Okay, so lifestyle, exercises, medications. What if those still aren't enough? What are the interventional options? Procedures, surgeries?
That's right. For those who don't get sufficient relief, there are more interventional options.
Well, for men first.
Sure. For men with persistent issues, especially stress incontinence after prostate surgery, options include urethral slings, which provide support, or for more severe cases, an artificial urinary sphincter, or AUS.
An artificial sphincter, how does that work?
It's basically a fluid-filled cuff placed around the urethra, connected to a pump in the scrotum. You squeeze the pump to deflate the cuff and urinate. It's highly effective with good long-term success rates, but it is a surgical implant, so it comes with its own considerations, like the potential need for future revisions.
Okay, quite involved but effective. What about for women?
For women with stress urinary incontinence, the midurethral sling, or MUS, is a very common and highly effective surgical procedure. It's often considered the standard due to high cure rates and being relatively minimally invasive.
The sling procedure, right?
Exactly. There are less invasive options too, like urethral bulking injections. Material is injected around the urethra to help it close better. These are less invasive, done in the office, but they might require top-ups over time and generally have lower long-term cure rates than slings.
Okay.
And while there's some buzz around newer methods like vaginal laser therapy, more research is definitely needed before they become widely recommended. The evidence just isn't strong enough yet.
Got it. Sling is still the main surgical option for SUI. What about for stubborn OAB or urgency incontinence?
Right, for persistent urgency urinary incontinence, OAB, that hasn't responded well to conservative measures and medications, we have advanced therapies.
Okay.
One is posterior tibial nerve stimulation, or PTNS. This is kind of like acupuncture for the bladder, but without needles penetrating deep.
How does that work?
A fine needle electrode is placed near the tibial nerve by the ankle, and mild electrical stimulation is delivered. This seems to modulate the nerve signals going back to the bladder, calming it down. It's typically done weekly in the office for about 12 weeks, then maybe monthly for maintenance. It has shown good efficacy.
Interesting. Nerve stimulation via the ankle.
Yeah. Another option is botulinum toxin injections. Yes, like Botox.
Botox for the bladder.
Exactly. It's injected directly into the bladder muscle during a quick cystoscopy procedure in the office. It relaxes the overactive muscle and reduces urgency and leakage.
How long does that last?
The effect typically lasts about 9 to 12 months, so repeat injections are usually needed. There's a small risk, maybe 5–10%, of it working too well temporarily, causing difficulty emptying the bladder, which might require short-term self-catheterization. But for many, it's very effective.
Okay.
And the last one. And finally, there's sacral nerve stimulation, or SNS, sometimes called sacral neuromodulation.
SNS?
This involves a small pacemaker-like device that's surgically implanted under the skin, usually in the upper buttock area. It sends mild electrical pulses via a thin wire to the sacral nerves, which control bladder function.
So it's like a pacemaker for the bladder.
Kinda, yeah. It's typically reserved for more refractory cases, people who haven't responded to other treatments. But many patients see significant, really life-changing improvement. Reported response rates for urgency incontinence can be as high as 89% at 1 year.
Wow, that's impressive for difficult cases. It really sounds like there's an incredibly comprehensive toolkit of options available depending on the individual, truly offering a pathway to significant improvement for almost everyone dealing with.
Absolutely. What's truly striking here is just how common urinary incontinence is, yet how often it's dismissed or just ignored. But the overwhelming good news, the main message, is that from simple lifestyle changes and targeted exercises all the way up to advanced medical and surgical options, there's a strong, evidence-based roadmap for effective treatments.
Yeah.
The key is understanding that there are many paths to improvement, and you absolutely do not have to suffer in silence.
That really is the most crucial takeaway, isn't it? Don't suffer in silence. Incontinence isn't just some minor inconvenience. It can severely impact quality of life, leading to isolation, anxiety, distress.
Huge impact.
But help is out there, and the very first step always is to talk to your doctor. It is often highly treatable.
Exactly. Just imagine for a moment the profound impact that maybe 1 or 2 relatively small changes, perhaps really consistent pelvic floor exercises, or a minor adjustment to your fluid intake, or talking about that medication side effect, could have on a daily struggle you might have simply dismissed as, oh, well, I'm just getting older. It really might just transform your quality of life.
That's a powerful thought to end on. Thank you for joining us for this deep dive on urinary incontinence.
Yes, thank you. And if you found this information helpful, please share it with anyone you think might benefit. And remember to subscribe to What the Study Says for more insightful discussions. We'll see you next time.